So the TAVR procedure is a percutaneous procedure, and we have evolved in doing this procedure over a period of time. Now this procedure is done as almost like 3 or 4 procedures per week in our hospital. We access the body through the femoral arteries, where we put a large tubing on the right leg and a small tubing on the left leg, and we have got information about the patient's requirement of the TAVR valve by a contrast CT, which is performed before we plan the procedure. This contrast CT helps us to understand what size of valve, which valve, and what is our access, because the most common and the most comfortable access is the femoral access, although there are other alternative accesses which can be used. So we access the body mostly with the main device, which is the valve going from the right femoral artery. We take our wires through the right and the left femoral artery to cross the aortic valve, which is the valve between the left ventricle and the main tube of the body, which is called the aorta, the aortic valve. And this procedure is done mostly for patients who are more than 70 years of age, who cannot be operated or are high risk for surgical treatment. The planning is done, as I said, by doing a CT. We know the size of the valve which will be required. We know how the access would be. And to guide our procedure, which is controlled by an X-ray, which is because the procedure is done in the cath lab, and we do our procedure mostly in the hybrid cath lab. We go into the heart, crossing this valve, which of course is a slightly difficult phenomena because the valve is very small. We first create some passage by opening the aortic valve with a balloon. We call it pre-dilatation. And then we take the device, which is advanced over a wire system. All of these procedures are done under X-ray guidance and using contrast and contrast injections in various parts of the heart. The device is inserted and railroaded through the wire, which is already present, into the left ventricle after the valve has been pre-dilated with an adequate size of balloon. Then the valve is taken to its final destination, which is the aortic valve, which is patient's native aortic valve, where either we use 2 technologies. Of course, one is balloon expandable technologies, another is the self-expanding technology. And the wire with a certain previous understanding about how to deploy, where to deploy, is ultimately deployed, and the patient is taken care of. Most of these procedures we do will not take more than 45 minutes to an hour and a half. The procedure is completely, of course, we do it under local anesthesia. Most of our procedures are done under local, and we do it without any sedation as well. For more information about TAVR or transaortic valve replacement, reach out to your healthcare professional. Choose TAVR without compromise.